Dear respected students, today we will talk about the syndrome of diffuse lesion of connective tissue. We are continuing circle of rheumatology lectures, and syndrome of diffuse lesion of connective tissue is characterized by systemic autoimmune lesion of connective tissue and its derivatives. And before discussing this syndrome, I'd like to remind you connective tissue components. There are ground substance, connective tissue fibers, and connective tissue cells. As you know, connective tissue cells, they have a very unique, each one has very unique function, like fibroblast, mast cells, macrophages, plasma cells, and leukocytes. And connective tissues fibers, there are collagen fibers, reticular fibers, and also elastic fibers. Here is sometimes types of connective tissue. For example, loose connective tissue, which localized under the skin, and adipose tissue, also blood, which contain plasma and blood cells, and fibrous connective tissue, and cartilage and bone. And you see in diffuse connective tissue disorders, disorder has multiple clinical picture because will damage each of these types of connective tissues. From anamnesis, connective tissue disorders has genetic predisposition and predominantly affects female, most common in female, and most common affects young people, shows tendency to progression and recurrence, and sometimes can spontaneous remission likely. These disorders has very difficult pathogenesis, and pathogenesis started from particular of immune-related genetic susceptibility, also with combination with external stimuli like environmental factors, like infections, like insulations, or maybe hormonal inducing. Both these components can cause the immune dysfunction, and dysfunction of immunity. As a result of dysfunction of immunity, released autoantibodies and inflammatory cytokines, which cause inflammatory reaction of by whole organs and tissues. Features of this immune reactivity, this formation of abnormally activated T and B cells, and overexpression of B and T cells, co-stimulatory ligands and receptors, higher concentration of B and T cell cytokines, increased numbers of antibody-producing B cell, hypergammaglobulinemias, autoantibody production, and immune complex formation. As a result of these T and B cells activation, we have inflammatory reaction of whole tissues. Pathogenesis, here sequence of pathogenesis, deterioration of suppressive activity of T lymphocytes, activation of contrasuppressors like T helpers and B lymphocytes, impairment of idiopathic regulation, abnormal excretion of HLA antigens. Regardless the cause of impairment of regulation, general signs of autoimmune disorders is B cell activation, polyclonal or autoantigen specific, resulting in hyperglobulinemias and excessive formation of antibodies with different specificity. Connective tissue disorders, this syndrome may present in many kinds of disorders, in hereditary disorders and acquired, like Marfan syndrome or maybe Alport syndrome, and etc. And most common, of course, acquired systemic connective tissue disorders like systemic lupus erythematosus, rheumatoid arthritis, systemic scleroderma, Sjogren syndrome, polymyositis, and dermatomyositis, even mixed connective tissue disease. This connective tissue disorders has multiple clinical picture because of damaging of whole organs and systems, and represented by general inflammation syndrome, involvement of skin, involvement of skeletal muscle system, clinics by serous membranes, and can damage the vessels, can damage the excretory glands and internal organs like visceritis and lymphatic nodes. and commonly involved organs and systems. Here is central nervous system, also most common involving of kidney, eye, mucous membrane, GIT system, heart and lungs, and also can involve the damaging of skin, of course, hematological involving, and destruction of muscles and bones. General inflammation syndrome recognized by fever. Fever character persistent and prolonged fever. Sometimes fever and loose weight is the early symptom of connective tissue disorders. Also, increased USR and other inflammatory disorders will increase the C-reactive protein, and this by C-reactive protein we also can assess the activity of connective tissue disorders. Trophy impairment, represented by alopecia, baldness, can be either diffuse or local. Loss of weight, altered nails, and dryness of skin. Of course, here we have changing of immune system, and this changing represented by lymphadenopathies, enlargement of lymphatic nodes, sometimes hepatomegaly, enlargement of liver, and splenomegaly, enlargement of spleen. Here you see local alopecia in systemic lupus erythematosus, and involvement of skin represented by dryness of skin, hyper and sometimes even depigmentation, allergic rash, or non-specific rash. Specific symptoms also takes place. For example, facial erythema is butterfly shape, character for systemic lupus erythematosus. This is erythema of cheeks and dorsum of nose. Solid edema induration or atrophy, character for systemic scleroderma. Periorbital heliotropic edema or eyeglasses as eyeglasses shape, and erythema nodosum of open body parts, character for dermatomyositis, and hemorrhagic rash on lower extremities as in purpura rheumatica, character for SLE, systemic lupus erythematosus, or systemic scleroderma, and also sometimes may be represented by telangiectasias in systemic scleroderma. Here you see butterfly shape erythema in systemic scleroderma. Also you see here induration and thickening of inflamed skin in with the couch-like mouth in systemic scleroderma. For example, here also rash represent us systemic lupus erythematosus, and here heliotropic rash, purple heliotropic rash, character for dermatomyositis. And dermatomyositis may be again his heliotropic rash, or also heliotropic rash, and also erythema of opened area like V sign and shoal sign of erythema, and also Gotron size. This is macular papules over the hand joints. You see Gotron size of dermatomyositis. Sometimes may appear lupus scolitis. This is congestive hyperemia with solid dry gray scales, sometimes with crust and erosions resulting in atrophy on red lips border. And also you see here purple rash in dermatomyositis, and also here we have sometimes papular macules in systemic lupus erythematosus. Capillaritis also takes place. Erythematosus squamous erythema on palm in systemic scleroderma, and in systemic scleroderma maybe there are many stages. Some stages are solid edema. This is early sign of scleroderma, sclerodermic changing of skin, induration and atrophy, late stage, alternation of hyperpigmentation and depigmentation of skin in induration stage. mask-like face and pouch-like mouth. Here also pouch-like mouth, mask-like and mimic face with the hyperpigmentation, depigmentation, and with the telangiectasias. Here also telangiectasias, and here sclerodactylias. Lesion of skin in scleroderma cause hyperemia of the base of nail bed with skin atrophy with persistent crackles and even scaling. Nodular rash, character for dermatomyositis and mostly for sometimes in systemic lupus erythematosus, and also lesion of mucous membrane with the ulcer formation also takes place in systemic lupus erythematosus and other diffuse connective tissue disorders. Joint syndrome represented by arthritis, arthralgias, periarthritis, tendage vaginitis, and contraction. Arthritis mostly occur as a polyarthritis, but sometimes maybe monoarthritis or oligoarthritis occur. Lesion of arthritis, lesion of joints, arthritis, inflammation of joints. Your patient will have pain and swelling caused by exudative inflammation phase, increased temperature of skin, pain in joints. Please remember last hour lecture, arthritis lecture. Periarthritis also takes place, inflammation of periarticular soft tissues, inflammation of tendon, and limitation of joint motion, can be flexion or extension. In systemic scleroderma and less common in systemic lupus erythematosus occur subluxations, ulnar deviation, and deformation due to weakness of tendigenous ligamentous apparatus takes place. Erosion lesions are commonly found in X-ray and recurrent polychondritis, and erosion also occur in rheumatoid arthritis. In diffuse connective tissue disorders are frequently reversible because usually caused by periarthritis or pain. Flexion contraction of hands in scleroderma, it takes place, infiltration of skin in scleroderma, and also not only damaging of skin, also you see in picture damaging of joints and contracture formations, and also atrophy of muscles. And also you see muscle atrophy and with the peripheral neuropathies and infiltration of skin. Involvement of bones represented by ostealgias, pain in bones, or osteoporosis, reduction of body mass caused by impairment of protein metabolism or increase of catabolic processes and inflammation. Another cause of iatrogenic osteoporosis due to prolonged time using glucocorticoids also can be developed in the aging process and can be complicated with pathological fractures. Osteolysis, decomposition of bone tissue, usually nail bones, caused by vascular trophic impairment, manifests with shortening of hand fingers. Aseptic bone necrosis, complete necrosis of spongy substance and bone marrow, while cartilage does not change. Also, cartilage may change as a secondary process. Main location is femoral head and head of humerus. And calcinosis, we have here on the one hand we have osteoporosis, reduction of body mass, and accumulation, deposition of calcium in around the joints and soft tissue around the joints and along fascia and tendons can be detected by X-ray methods. Lesion of muscles is typical for all diffuse connective tissue disorders, especially frequent in dermatomyositis, and dysphonia is frequent in systemic scleroderma. Hypertrophy of muscles, usually it's called amyotrophy, this is not very correct. Reduction of muscle mass. Myalgia, pain in skeletal muscles. Myositis, Inflammation of muscles, mainly striated, sign are pain, swelling, later develop hypertrophy and myofibrosis and contractures. And myasthenia is a weakening of muscles, and a weakening of muscle is so high even our patients couldn't take up his hand, wave his hand, even at a late stage, even couldn't sit down. Dysphonia, hoarseness of voice due to involvement of vocal ligaments, also may develop dysphagia, more corrective for systemic scleroderma. This is impairment of swallowing. Patients needs to wash down solid food with some liquids. Dysfunction of sphincters and urine bladder caused by impairment intestine muscles, urine bladder, and dysfunction of sphincters and urine bladder may be represented by involuntary urination. Impairment of diaphragm causing signs of lung hypoventilation appear. Impairment of intercostal muscles also lead to decrease of vital capacity and hypoventilation and cause breathing impairment. It also involves the serous membrane, because serous membrane, pleura, peritoneums, pericardium, they consist of consist of connective tissue. Pleuritis occur. Pleuritis, inflammation of serous membrane. Inflammation of pleura can be dry or exudative. Pericarditis also may be dry or accumulation of fluid. Peritonitis, inflammation of peritoneum, and polyserositis. Involvement of vessels represented by vasculitis. Generalized vasculitis, inflammation of vessels is component of visceritis and can develop also independently. It's typical for whole types of diffuse connective tissue disorders. Capillaritis, reddening of finger ends, especially clearly can be seen on the dorsal side, especially typical for systemic lupus erythematosus and dermatomyositis. Digital arteritis are area of necrosis around nail bed, and phlebitis, inflammation of veins. And it's very unique. We have here one syndrome as Raynaud syndrome. Raynaud syndrome is episodes of constriction of small arteries, arterioles of extremities, signs of which are paleness and or cyanosis and numbness of hand fingers, less frequently underexposed to cold and or stress. Pulmonary hypertension has complicated genesis. Sometimes it's an equivalent of Raynaud syndrome, can be caused by fibrotic process, and sometimes pulmonary hypertension may develop because of interstitial lung tissue and involving of vessels lung vessels in pathological process. Digital arteritis, you see here reddening, bed of nails, and which cause also arteritis. Digital capillaritis. Raynaud syndrome, you see here pale in one size. First will change into the pale and then cause cyanosis and even can cause a rash. After, for example, after taking something cold or after stress, may develop this kind of Raynaud syndrome, changing of color because of first spasming and then enlarging of vessels. This abnormal reaction of vessels to the external factor as stress or as cold. Vasculitis and Sjogren disorders may result in the even necrosis. Decreasing blood supply with the capillaritis can result in decreasing blood supply, even shortening, even necrosis and even shortening of fingers. Also may, in diffuse connective tissue disorders, may damage the central and as well as peripheral nervous system. Peripheral nervous system represented by polyneuropathies, multiple lesion of nerve trunks, most commonly caused by vasculitis of vasa nervosum. Central nervous system represented by different types of psychosis, advanced mental impairments like delirium, hallucinations, impairment consciousness, even till coma developing. Neural lupus occur in systemic lupus erythematosus, includes psychosis and polyneuropathies, represented headache, epileptoid attacks, hemiparesis, motor impairment, ataxia, neuritis, meningitis, myelitis, neuropathies. And blood damaging can cause the damaging of coagulation factors and represented by disseminated intravascular clotting syndrome, and this is complication of diffuse systemic disorder. This syndrome, severe pathological process in which circulating blood is clotting everywhere and blocks vascular system with soft mass of fibrin and cellular aggregates, which means that the blood exerts coagulation potential, after which it loses ability to coagulation, which result in profuse uncontrolled hemorrhages. It means first stage it will be clotting, excess clotting formation anywhere in small vessels, and then exertion of coagulation potential of blood, and last stage this is uncontrolled hemorrhages, and often complicates of systemic lupus erythematosus. Antiphospholipidic syndrome is also a unique syndrome, venous and arterial thrombosis, thrombocytopenia, spontaneous abortion, pulmonary hypertension, Raynaud syndrome, pulmonary capillarities, livido reticularis, involvement of central nervous system, common in systemic lupus erythematosus, caused by presence of antibodies to phospholipids. Lupus anticoagulants causes false positive rheumatoid RV Wassermann reaction and antibodies to cardiolipemia. CREST syndrome may be one of criteria of systemic scleroderma. This is combination of syndromes and symptoms described like carcinosis. C is carcinosis, R is Raynaud phenomenon, E is phagitis, S is sclerodactylias, specific changes of skin of wrist fingers, and telangiectasia is vesicular stars, and more specific for systemic scleroderma. Visceritis, this is syndrome caused by involvement of internal organs and even can damage the whole organs, including the heart, including the lungs, including kidney, and can damage the liver and spleen. And you see, risk of myocardial infarction is more than 50 times greater for women with systemic lupus erythematosus in age 35 to 44. Cardiovascular diseases is an ongoing issue for patients with systemic lupus erythematosus, and compared to the general population, incidence rate of myocardial infarction much higher in women with systemic lupus erythematosus. And you see here why higher. On the one place, of course, this is accumulation of formation of pro-inflammatory HDL. We know that HDL, this is very good lipoproteins which react against the LDL. But this HDL of people who is suffering from systemic lupus erythematosus become to be pro-inflammatory HDL. Here change his position. In the inflammatory state, HDL may lose their protective capacity and become to pro-inflammatory, and be presence of pro-inflammatory HDLs instead of HDL, normal HDL. likely in future to be a good measure of propensity to develop atherosclerosis independent of absolute lipid values. And that's why in systemic lupus erythematosus we have 50 times greater cases of myocardial infarction than in women which is not suffering from systemic lupus erythematosus. Also, pulmonary damaging of pulmonary tissue, most common in diffuse connective tissue disorders, and represented by pleuritis, also pericarditis, pneumonitis, and alveolitis, pulmonary hemorrhages, pulmonary fibrosis, shrinking lung syndrome, and sometimes develop pulmonary embolism if we have antiphospholipid syndrome developing of disseminated intravascular coagulation syndrome, and pulmonary hypertension. Gastrointestinal manifestations appears by peritonitis, mesenteric vasculitis, vasculitis of the bowel, inflammatory bowel diseases, autoimmune hepatitis, and even pancreatitis. How we diagnose? Diagnosis is very large, and first, of course, on the first place, we should investigate the blood count. Hemoglobin can indicate anemia, mostly character for rheumatoid arthritis and other disorders. RBC mostly represented by changing normocytic, normochromic anemia, macrocytic, sometimes maybe it develops pernicious anemia, and sometimes may develop autoimmune hemolytic anemias. Urine examination, reflection of renal pathology, represented by proteinurias, it develops glomerulonephritis, and sometimes you may be represented as hematuria or hemoglobinurias. Sometimes hemoglobinurias occurs occasionally with an acute exacerbation of hemolysis in autoimmune hemolytic anemias. And hemosideruria also belongs to the autoimmune hemolytic anemias. Hemoglobinurias and hemosiderurinurias are not character for other kinds of disorders like systemic lupus erythematosus or rheumatoid arthritis. This is character for if develop autoimmune hemolytic anemias, autoimmune damaging and destroying of RBCs. Oliguria may take place and will be complications like lupus nephritis or complications of systemic scleroderma. White blood cells should be very attentively investigated. For example, in eosinophilias may present in 80% of Church-Strauss syndrome, or for example, normal or moderately decreased maybe in autoimmune hemolytic anemia. Leukopenia, most common in active systemic lupus erythematosus, and also may be seen lymphopenia. Platelet counts and low or normal count character for autoimmune hemolytic anemias, and maybe sometimes decrease in other kinds of disorders. Also, you should investigate the reticulocytes count. Its count increase, compensatory increasing in hemolytic anemia, and ESR is very important analysis. This is indirect measures of the inflammatory process, very important for important clue for systemic autoimmune disorders, monitoring and treatment efficacy, and it can indicate acute phase response, returns to normal during remission. And if you want to check patient to the systemic lupus erythematosus, LU cells analysis, it's very important. What is LU cell? Cell is a neutrophil that has engulfed the antibody coated nucleus of another neutrophil. May appear in rosettes where there are several neutrophils vying for an individual complement covered protein. And C-reactive protein also takes place, is widely used for assessing disease activity in autoimmune disorders like ESR, and it's good prognostic and follow-up markers. Rheumatoid factor is autoantibodies, usually antibody immunoglobulin class M, directed against the Fc portion of the immunoglobulin G molecules, and found in more than 2-3 of adults with rheumatoid arthritis, and can be found in other conditions, associated conditions with systemic lupus erythematosus and as Sjogren syndrome, and etc. And anti-CCP or anti-cyclic citrullinate peptide antibodies can be detected also in 50% of rheumatoid arthritis and be positive in other kinds of rheumatoid disorders. Anti-nuclear antibody are antibodies that are directed against several nuclear antigens and can be grouped into 4 categories: antibodies to DNA, antibodies to histone, antibodies to non-histone protein bound to RNA, and antibodies to nuclear antigen. And anti-nuclear antibody ANA test, a marker of the autoimmune process, that is positive with a variety of autoimmune disorders, not only in systemic lupus erythematosus. It may be positive in lupus, maybe in Sjogren syndrome, in rheumatoid arthritis, and autoimmune hepatitis, and even in hepatitis B. And there are several kinds of methods which can detect the autoantibodies, and we can use the immune fluorescent microscopy methods, we can use the double immunoffusion methods, or immunoblotting methods. It's very good methods, and dot blot or linear blot, or we can use the ELISA, for example. This is technique that measure the amount of specific protein in a solution. How called? This is enzyme-linked immunospecific assay, and there are different methods by which we can detect the autoantibodies. This is immunofluorescent of anti-nuclear antibodies, for example. Anti-neutrophil cytoplasmic antibody ANCA will be detectable mostly in vasculitis. Detection methods, there are also very different kinds of detection methods, and there are 2 kinds of ANCA, P ANCA and C ANCA antibodies, and also may investigated complement assay. For example, SLE is the most common rheumatic disease associated with low serum complement level, especially C3 and C4 and C1q. The monitoring of serial complement levels provides a useful parameters of disease activity, and similarly, serum complement level are useful in monitoring the response to treatment. And sometimes, of course, we should investigate the association of HLA with diseases. And you see here most common associations is which we can find in ankylosis and ankylosing spondyloarthritis and spondylitis. We association with HLA B27. And in Sjogren syndrome associated, you see DR3, and rheumatic arthritis associated with finding of DR4. And also tissue diagnosis. It's also very important. For example, in dermatomyositis, gold standard of putting diagnosis is biopsy. We can take to biopsy each different kinds of tissues, and which is processing by hemotoxylin eosinophil staining, or we can use direct and indirect immune fluorescency, or we investigate by electron microscopy or immunoelectromicroscopy for localization of deposits. Here is examples of kidney biopsy in systemic lupus erythematosus, and skin biopsy also it takes place, and salivary gland biopsy, for example in Sjogren's syndrome, which are mostly damaged in Sjogren's syndrome, and all biopsy, muzzle biopsy, and dermata and polymyositis. They are different in dermata and polymyositis. For example, in polymyositis are represented by CD8 cells and endomyocele, and in dermatomyositis are mostly represented by B cell. And synovial biopsies. Besides biopsy, also we can, in dermatomyositis and polymyositis, or all the disorders which cause the myalgias and myasthenias and myositis, we can use methods electromyographic investigation. Electromyographic investigation. Here is differences between the myogenic lesions and neurogenic lesions, different kind of disorders. And such kind of investigation as MRI, CT scan, ultrasound, it takes place. And MRI, it's very useful methods, because on MRI we can see and detect not only joints and not only thick tissues, also it will be detectable even edema of muscles and soft tissues. And here respect we know that different kinds of autoantibodies may present in many kinds of disease. For example, ANA may be positive in systemic lupus erythematosus, ANA may be positive in rheumatoid arthritis or other kind of disorders, and to detect we should use the we should combination of positive antibodies. And here, for example, combination of autoantibodies in Sjogren's syndrome, combination of antibodies in lupus erythematosus, or in systemic rheumatoid arthritis or systemic sclerosis, and etc. Okay, thank you, my dears. I'm finishing my lecture. If you have questions, you know how you can get answers.